you now?
Yes, ma'am. Yes, ma'am. Definitely.
So a 4-week child is suffering from recurrent vomiting just after the feed and it's not gaining weight.
Ma'am.
So can you tell me what are the differential diagnosis?
For a 4-week child who is having recurrent vomiting, the likelihood can be a congenital pyloric stenosis. There can be infective causes like any upper GI infection. It can be because of persistent sepsis. It can be because of other infections causing vomiting. It can be probably because of toxins also. That's the only thing I can think of.
Okay, fine. So can you tell me, suppose this child has the pyloric stenosis. So can you tell me what is the metabolic problem in pyloric stenosis?
So the metabolic problem is basically hypochloric metabolic alkalosis, which is there. So basically the kid has persistent vomiting, which causes loss of electrolytes. So there is a decrease in the sodium levels, there is a decrease in the chloride levels. And because of the metabolic alkalosis, there is a tendency of the kidney to retain hydrogen ions, which actually causes which basically is by excreting potassium ions and retaining hydrogen ion. So the kid really ends up with the decrease in the electrolyte, like decreased sodium levels, decreased chloride, and decreased potassium levels.
Okay. So what do you think? The urine will be acidic or alkaline?
The urine, I think urine would be because it's retaining hydrogen ions, so it should be alkaline.
But that is a aciduria. Why is it so?
Is it because of pre-renal failure? That can be one of the cause, or it can be because of the acidosis.
Aciduria. I'm asking, acid is the actual term metabolic problem that goes as hypokalemic, hypochloremic, metabolic alkalosis with paradoxical aciduria.
Aciduria, yes, ma'am.
Why, if as per your explanation, the body will try to retain back acid. So why there will be aciduria?
I'm not sure about that.
Okay. So can you tell me what are the anesthetic challenges in a case of pyloric stenosis?
Ma'am, the anesthetic challenges that come up in a pyloric stenosis can be, first is that it's a neonate, so there are challenges associated with being a neonate. Then there are
what are the challenges of a neonate?
Ma'am,
what are the challenges of a neonate?
In the neonate, I'll probably divide the challenges into different categories. So there can be airway issues, there can be respiratory issues, there can be cardiovascular, there can be temperature-related CNS, metabolism, which can be hepatic and glucose. Then there can be impairment in the thermoregulation, and there can be.
So why there will be impairment in the thermoregulation?
In the environment and the thermoregulations, these children have high body surface area, and they are likely to have a lot of heat losses, which needs to be prevented. And they have no mechanism for shivering.
So what is the intraoperative temperature you wish to keep for such neonates?
Usually it's around 28 degrees for the neonates, ma'am, that we need to for us to prevent hypothermia in these patients. Okay.
So what is the airway challenge you need?
For the airway challenges, ma'am, the first airway challenge is that they have a large head, they have a short neck, and the occiput is very, very prominent. So you need to position them in a way that you have to put a bolster or a little bow so that their neck can be elevated and it is easier, sir. The tongues are relatively large. The epiglottis is more floppy.
So
it
you
is
mentioned about A. What about B? You mentioned something on respiratory. What are the problem of respiration?
The respiration problem is that they are mostly nose breathers, ma'am. So any trauma or any kind of insult or edema during intubation can decrease the size of the airway. So we should be very careful. That's one thing, ma'am. Then the breathing is that it is mostly they don't have the ability to increase their tidal volume. So it is respiratory rate dependent. That is one. Then there are different kind of fibers that are present. So type 1 respiratory fibers are deficient in the neonate, so they are not able to sustain it for longer. So in case of any respiratory distress, it's important that an early intervention and oxygen supplementation is required for
About the circulation, you mentioned something on circulation. What
yeah,
about
the circulation, ma'am. The circulation part is that the kids usually their parasympathetic system is much more developed, so they are prone to have bradycardias. Then the cardiac, because of the ventricle being less compliant, ma'am, it is very difficult for the ventricle to increase the cardiac output by increasing the stroke volume.
what is the
So
fluid
the cardiac,
management? How do you give it? How do you decide for the fluid management for this child?
Uh, the fluid management, ma'am, usually for this pyloric stenosis or otherwise just
No, I'm asking for pyloric stenosis for this
uh,
case.
for the pyloric stenosis, ma'am, we have to usually correct the electrolytes. So it is important that if we can actually give Hartmann solution, we can give normal saline. It's mostly crystalloid, which is given at around 20 ml per kg body weight. But in case of severe dehydration, we can actually increase this to around 60 ml also per kg body weight.
To decide how much to be given uh, in a patient who is severely dehydrated.
Ma'am, we can actually do it by urine output. So urine output monitoring is being done in pyloric stenosis. So it's usually we maintain it around 2 ml. Then there are indirect signs like if there is signs of increased
You're aware
capillary
of the
refill.
formula which will direct you for fluid guidance for a replacement deficit fluid?
Yes, we can try ultrasound. Ma'am, we can see the IVC diameters.
No. I'm asking, are you aware of any formula to guide for the fluid deficit?
Ma'am, I'm aware of the maintenance fluid that we use for another 20 initial 10 kgs. We give around 4 ml per kg body weight. And
What is that formula?
ma'am,
What is that formula name?
I really forgot. It's been a long time.
Okay. So
yeah,
you mentioned
it's holiday sitar formula.
holiday. You mentioned that you will check for the urine output in this child. So what is the
Ma'am,
target urine output for a neonate?
ma'am, for the neonate, we take it as around 2 ml per kg body weight.
Okay. Apart from urine output, what else will guide you for the fluid therapy?
Ma'am, fluid therapy probably would be based on any metabolic acidosis if it is present, or
No, I'm asking what are the clinical signs you will look in a neonate to look for the
dehydration. For the clinical signs, ma'am, we look at the blood pressures. We can look for the capillary refilling. We see shrunken fontanelles. Fontanelles can be the signs of dehydration, and decreased urine output. These can be checked in a neonatal.
So will you do RSI or you will do a elective intubation in this case?
Ma'am, for this, it's important that we need to have because since it's a neonate and it is likely to be a full stomach, I would I would like to do RSI in this kid.
Okay, what is the analgesic strategy for your case?
Analgesic strategy, ma'am. I would probably like to first of all, since it's a kid, I would first like to apply if there is already an IV access, which I suppose is, then I would start with the inhalational induction with
No, I'm asking
sevoflurane.
about analgesia. Pain.
And analgesia. Okay, ma'am, analgesia in this kit, we can have multimodal analgesia. So I can give IV paracetamol, which is at the dose of around 7.5 mg per kg body weight. Then I can use fentanyl at around 1 mics per kg body weight, ma'am. And local infiltration at the site can be given. Usually it's a subcostal incision, which
Dose of
is
paracetamol you will give?
ma'am, 7.5 mg per kg body weight. 7.5 to 10 mg per kg body weight.
Fine. What are the pain assessment scales in neonates?
I don't remember that.
Okay. So we will stop you here. How you felt
Yeah.
about the accident?
I'm not really sure, ma'am. Probably
Are you
the
pediatric anesthetist?
no, I'm not. No.
You are not. Have you revised pediatric this week?
Yes, I have.
So, Dr. Jagni, to be I'm really happy this week. What I see is comprehensive people are really doing well. But I don't know if it is the clinical things has come up, that is the reason. But at least you people have picked up to some momentum now, unlike previous classes. So, it's good to see. So, you people are preparing well. Anyways, you answered many questions correctly. Few things were fundamentally wrong. Few things you could not pick up. So fundamentally wrong was why there is a paradoxical aciduria. Okay, so this
Yes.
you have to understand that what happened, what is the problem in in a pyloric stenosis is there will be a repeated projectile vomiting. Okay,
Ma'am.
when there will be a repeated projectile vomiting, there will be a continuous secretion, removal of the H plus ion as well as the chloride. So that is the reason for hypokalemia and hypochloremia. Okay. So as the potassium is coming out, as because the H plus ion is coming out, what initially the renal will do, it will try to throw out the bicarb also.
Okay.
That makes sense?
Yeah.
Yeah. So there will be initially metabolic, a very transient phase of metabolic alkalosis with alkaline urine.
Okay.
But again, there comes a situation because just not the potassium is going out, it is also the sodium as well as the water which is going out.
Okay.
So when there will be dehydration, there will be decrease in the intravascular volume, there will be activation of renin-angiotensin system.
Mm-hmm.
So there will be stimulation of the aldosterone. Aldosterone will try to retain back the sodium and water so as to maintain the intravascular volume.
Yeah.
At the same time, the work of aldosterone is to throw out the potassium and H plus ion.
Mm-hmm.
That is why that will be an acidic urine.
Acidic. Okay.
Okay. So you have to be very clear on this. You should not make any mistake. Then I asked you, what are the problem of a newborn? You mentioned about A. So if you mention about A, this is a good way of classification, patient related, surgical related and anesthesia related.
Mm-hmm.
So when you are answering neonate, when you told me about airway, I would strongly suggest you collaborate with the pathology. It's a neonate. It's a difficult airway. In addition to that, the patient is having a projectile vomiting. So there can be a chance of aspiration. So I might end up in doing the RSI. In the lieu where you wish to do a difficult intubation in RSI, it is further difficult. Also, in RSI you use choline, and the neonate has a parasympathetic overdominance.
So
Their
atropine can be.
cardiovascular system is completely dependent on heart rate. So there can be exaggerated bradycardia can be an issue. So pre-medication might be of use. This is especially when you use the second dose of choline, not the first dose. However, in RSI, we use a higher dose, and pediatric patients, since the body water is even more, even the use of the dose of choline is further increased. It's almost 2 mg per kg rather than 1.5 mg per kg. So chances of bradycardia is important. Their pulmonary reserve is less. as you have mentioned in B, the respiratory FRC is less. When the FRC is less and you're doing a RSI where you cannot do a proper pre-oxygenation of 3 minutes, the chances of rapid desaturation is high. So, expert pediatric anesthetist should be there for, or a best hand intubation should be taken into consideration. Then simultaneously comes with the problem with circulation. Here, fluid management you told wrong. I will tell you exactly how the fluid management has to be done in a newborn or a child pediatric case. I will tell you this answer. And I asked you about the D. You didn't mention about hypoglycemia once.
Yeah, they're prone to hypoglycemia. Actually,
where the baby cannot eat. This is one of the cases where the baby cannot eat. Chances of hypoglycemia can be there. So you have to talk on hypoglycemia as well. As well, you have to remember the levels of hypoglycemia. When you call, it's not like in the last mock Viva, I remember someone answered it's 80. 80 is for adult. For a newborn, it is 30. For an infant, it is 40. So the level of hypoglycemia definition is different. And exactly you have to remember when I will be teaching how much of glucose containing fluid has to be given. The traditional teaching was D10. It is no more D10. It is D1 to 2.5% which has to be given because they found the surgical response to the hypoglycemic response to surgery is more than the hypoglycemic response. That is why now they're cutting it off to 1 to 2.5% of glucose than the conventional 10%. Okay.
Ma'am, less than 40 for less than 40.
I will discuss those slides in detail. Just as a feedback, I'm telling, I will come to those slides properly. You will get a complete, you will remember everything. Okay. Then I asked you on hypothermia. I asked you why there will be hypothermia. You just told me why a newborn will hypothermia. You didn't touch anywhere why the newborn under general anesthesia will have hypothermia even more.
Okay. Basically, I need to correlate, ma'am. I was just thinking on maybe the general parts of neonatal.
Yeah. See, now I will teach you. Now in the subsequent slides, like that's why I have kept around 30 to 40 minutes, a good number of time so that I can cover those slides and I will teach you a pediatric and a neonatal anesthesia properly. Because I am sure once you read that, nothing is beyond that. That is too much. But correlating things, you have to learn and you have to practice doing it. So this something which I cannot help you out, and you have to think like that. Just to think a baby has come, it is in general anesthesia. So what precaution I will take? Why there will be more hypothermia? What has to be done? How do you define hypothermia? What is the OT temperature that has to be set? What is the forced air warmer that has to be kept at what temperature? What is the humidity that has to be set? All these are questions.
Okay.
The patient is continuously vomiting. Nowhere you mentioned about electrolytes.
Yeah, I told my once to correct electrolyte, I think.
Correct electrolyte. Again, yeah, I would say IHPS or CHPS is never a surgical emergency. If your surgeon is asking if the CHPS is an emergency, he is simply telling you it's a medical emergency. Correction of electrolyte is important. It is one of the conditions where the patient, if pH is more than 7.4 and less than 7.4 and your potassium is more than at least 3.5 to 4, then only you take up the case.
Okay.
Okay. So I will take you guys. So anyone has any doubt apart from hardcore the principles of basic of neonatal and pediatric anesthesia? Do you have any doubt related to CDH or this case IHPSS disease per se? Or should I move?
Ma'am, there is one for the fluid deficit calculation. There is one like percentage of hydration into weight into 10, ma'am.
Yeah,
the percentage of hydration, like with the core temperature or okay.
I will answer this question. Actually, in my slide, this topic is completely there. So let me first cover those slides and teach you once. After that, if you have any doubt, I will come back. Is that clear? Is that fine with you guys? Because it's a long slide. If I don't start, it will itself take 30 minutes.
Yes, ma'am. Yes.
Okay. So I will teach you once that slides. Once I'm like we finish, then we come back. Okay. So we'll start how a pediatric is different from an adult. Okay. So we will remember in the mnemonic of ABCD. So first is airway. So the first question that comes, how a pediatric airway is different from an adult airway. Here you have to remember the pediatric airway I mean is the age up to 8 years. After 8 years, pediatric airway is no more a pediatric airway, it is an adult airway. So if you look at the pediatric airway, so they as this Dr. Jagmeet has told, they have a large head, short neck and prominent occiput. What is the clinical relevance here? The head has to be formed in a neutral position, a shoulder roll has to be given. Then the tongue. Tongue is large in proportion to the oral cavity, so you have limited space for the manipulation of your laryngoscope. That's why if you are using a Miller blade, it is better than McCoy Macintosh blade in giving you a better space. Then comes the vocal cord. The vocal cord are anteriorly angled. So what happens whenever you put a tube, you will end up in hitting up the anterior commissure and you do not intubate. You fail to intubate. So here you have to do a maneuver of 90-degree or 180-degree rotation so that the angulation of the anterior commissure is removed. Then comes your epiglottis. Epiglottis narrower, omega shape and floppy posteriorly. So what is the problem here? You have to lift the epiglottis. That is why the Miller blade is preferable. And when you lift the epiglottis, there is an abundance of the superior laryngeal nerve, which causes a bradycardia. So a bradycardia is a problem when you use a Miller blade. You have to be careful. Then larynx. Larynx is the anterior and high. The level is C3 to C4 as compared to C5, C6 in adult. This is a question they might ask you. What is the level of larynx in a pediatric as compared to adult? Then comes the cricoid. Cricoid is conically shaped. Here is a controversy. Recent cadaveric studies have found there is not a funnel shape, it's an elliptical shape. So you should know the recent advances as well. And the narrowest part is at the level of the cricoid. That means the tube that passes through the vocal cord easily may not pass the cricoid. So always you have to keep, and subglottic stenosis is a very well-known entity in the case of a newborn and a pediatric patient. So always you have to keep your a lower size CT tube ready as well. Then comes your trachea. Trachea is deviated posteriorly and downwards. In neonates, the distance is almost 2 centimeter towards to the carina is the distance. And the angle are almost similar. Like in adult, one side is 25 degree in the left side and 45 degree in the right side. Whereas in case of a pediatric, the angulation is similar on both sides of around 45 to 50 degree. So in adult, the chance of right-sided endobronchial intubation is high, whereas in case of a pediatric, there can be equal chances of endobronchial intubation. So auscultation post-intubation of positioning is very essential. Then comes a nasal breather. So they're obligate nasal breather up to 1 year. So in patient of choanal atresia, if you block their nose, they cannot breathe and they can go for an absolute desaturation. Okay. So these are the things which, so they're prone to airway obstruction. For that, you have to do a triple maneuver. That is a elevation of a jaw thrust, chin left and mouth open. So this I have already spoken already whatever I had discussed. So next comes also this trachea, it is short, this I've already mentioned. So comes to B for breathing. So what happens, the rib cage. So they have a, you can see in adult, we have a buckle handle shape. So they have a horizontal kind of rib cage. So it is moved like this. So this will limit the tidal volume. So their reserve is very less. And their chest, what the lungs and the chest wall always moves in an opposite direction. When we inspire, the lungs try to expand, the chest wall try to move inward. So it will not let the lung to expand indefinitely. And the reverse happened during expiration. Here the chest wall compliance is very much increased. That means during expiration, when the baby tries to exhale out, the chest wall should try to move outwardly so that the lung should not get in too much. But that doesn't happen here. The chest wall will compliance is so much increased that when the lung is collapsing, it will also collapse. So that is why the FRC is low. Okay. So in case of any abdominal surgery, when there is a bulky abdominal content like obstruction, perforation, they will cause the further impingement on the diaphragm. There will be diaphragmatic splintering. So in such case, you should always use PEEP. In newborn, is the biggest misnomer among non-practicing pediatric anesthetists that PEEP should not be given. Rather, in newborn, a PEEP of at least 4 to 5 should always be given. Okay, because you have to overcome the resistance of the tube, and they have a physiological autopip mechanism in newborn which keep their alveoli open, which is diminished under anesthesia. That is why PEEP is a must in pediatric or a newborn patient. Second comes a muscle of diaphragm, respiration. So normally we know the respiratory muscle of inspiration is mainly the diaphragm. And diaphragm has two type of cells, type 1 cells and type 2 cells. Type 1 cells are the good cells which are fatigue resistant. Type 2 cells are the fatigue prone. They have a very 10% of our just type 1 cells, and there that transition happened by second year of life. So as well as when there is a problem with the intercostals or the diaphragmatic muscle, usually the abdominal muscles take the upper hand. Here their abdominal muscles is not well developed. So basically their rib is also their skeletal is a problem. Second is also the muscles. At the same time, their consumption of oxygen and CO2 production is very high because the BMR is high. So your pre-oxygenation is a mandatory and they're prone for desaturation. Then comes the alveoli. The alveoli are thick-walled and only 10% of the total alveoli that we found in adult is found in a newborn. They almost take the first 8 years to develop. Then comes the ventilatory drive, their hypoxic hypocarbic drive or worse. And how do you define apnea of prematurity if it lasts for more than 15 seconds and is associated with desaturation and bradycardia? This is very important. Just telling apnea of more than 15 seconds is not sufficient. And if the baby has apnea of prematurity, what you should do first is observation, then it comes to caffeine. And man, those should not exceed 900 mg per day. That I have to say 10 mg per kg is the loading dose. Total dose I will check and get back to you. C comes the cardiovascular. So what happens in a newborn? There is a flip-flop circulation. So there is the ductus venosus, the ductus arteriosus. So initially there will be very high pulmonary vascular resistance, and there will be decrease in systemic vascular resistance. So blood never got the chance to get into the lungs. As soon as the baby get the first inspiration, the lung expands and there will be the cut of the umbilical cord will increase the SVR. That is why the blood start going into the lungs. But this is a flip-flop circulation. Any condition like hypoxia, hypocarbia, acidosis or any anesthetist which will increase the PVR will let this foramen oval or the foramen ductus arteriosus to reopen again. That is why if you notice in many newborns who come to in early age of surgery, they later come to your follow-up with a problem of PDA, patent ductus arteriosus. Remember, this is not their inborn problem, rather it is the anesthetist, it is us whom by means intraoperatively we have not maintained these factors and we have increased the PVR. That is why they have come with PDA. So next, what Dr. Jagdish has mentioned this point, cardiac output is equal to heart rate into stroke volume. So in pediatric newborns, their muscles of the myocardium are not well developed. So cardiac output is predominantly heart rate. predominant, and as such they have a parasympathetic overdominance over sympathetic. So they are very much prone to bradycardia, and bradycardia will cause a serious collapse quickly. So they have a fixed cardiac output tone. So you should not, that is why the cardiac compensation, if there is a CPR is needed, if the heart rate is less than 60, whereas for adult it is less than 30. That because their heart rate, it is a heart rate dependent circulation. These are the few differences which they have asked in recent exam also. What is the difference in cardiac between the neonate and the adult? So based on whatever point I have already mentioned, contractility, stalling response, compliance, afterload compensation, and cardiac output. You can take a picture and you have to remember these points which I have already given the explanation. So Dr. Jagdish mentioned we have to check for the blood pressure. You know, blood pressure is a very bad monitor in a pediatric because the cuff will be very inappropriate. And here is the systolic blood pressure, not the mean arterial blood pressure, which has to be taken into consideration while you talk about blood pressure. So if at all you wish to talk about blood pressure in a newborn, so you talk about the systolic blood pressure rather than a mean arterial blood pressure, which happens in an adult. Next comes the blood volume. In any newborn surgery, be it CDH or it's IHPSS, always talk about the blood grouping and cross matching. Because the blood volume is very important case. In premature neonate, the values are around 95 mL per kg. In term, that is 93 to, these are the numbers. So what is important is, if there is even 10% of blood loss, it accounts to a big amount of blood loss. For you, it is just 10 ml, 20 ml, but if you go by percentage, it goes to a bigger percentage. That is why their threshold for blood grouping, blood transfusion is less. Then D for disability. Again, this point you can always talk. If it's a premature newborn, their blood-brain barrier is not well matured. So many drugs like barbiturate opioids, they can cross the blood-brain barrier, and the CNS depression effect of the respiration secondary to the opioids can be a major problem. Second thing is their cerebral blood vessels is involved and fragile. So what we have seen in non-pediatric practitioner is that what they do is they try to intubate the baby awake of the fear that they will lose the airway. But especially in premature, they have the problem of intraventricular hemorrhage. They land up in intraventricular hemorrhage because their vessels are very thin. So any stimulation which is very big will definitely cause their damage to the vessel. Also, another problem is the lack of cooperation. So you don't have to deal with a single patient here. You have two patients, the anxious parent as well as the child. So here comes the distraction method. Premedication and exolysis are very important. So you have to have a good patience. However, this thing is not applicable in a newborn. Especially you have to this premedication is not needed till 6 months of age. Then, apart from that, how a pediatric spine differs from an adult spine, this is very important if you are talking about your central nervous cell blockade. So in neonate, the durameter ends at S3, whereas the spinal cord ends as L3, whereas in adult it is S1, L1. So you have to go for a lower approach if you are going for a pediatric spinal, neonatal spinal. Then comes the CSF. The percentage of the CSF distribution is 50-50. Like 50% of the CSF is in the cranium and 50% is there in the spinal cord. Whereas in case of an adult, 33% is there in the cranium and 67% is in the spinal cord. So because there is a greater dilution of the drug here, I just told the reverse ratio. The spinal cord is to CNS ratio. So because it is 50, whereas it is 33, so here the drug dilution will be more. That is why you need to give a more of a higher LA volume. Then comes the meningitis. The meningitis is a highly vascular neonate. That is why the local anesthetic take-up will be faster. That leads to a shorter duration of action of local anesthetic. That is the problem. What happens to the newborn spinal? That is why it is only indicated what is clinically used only in cases like hernia, which is a short duration surgery of less than 30 to 40 minutes. Then comes myelination. They have a loose endothelium. So that is why the drug migrates first and that have a faster onset and offsets. Next come the ligaments. The ligaments are very less dense, so they have a higher sensory blockade. Then E comes the exposure. So they have a greater heat loss because of the thin skin, low fat content, and high surface area ratio. At the same time, their heat production is less. because there is no shivering up to 3 months, and there is thermogenesis predominantly by the brown fat, and they have a less developed vascular and behavioral adaptation. I will stop this thing here. I will talk this point more in a better way in next another PPT. Okay, just temperature, this much you remember as of now. Coming to fasting guideline, initial guideline was 642 guideline. However, recent guideline has come, which now have reduced this time. This also I will tell you in one more slide. So you, as of now, you remember E and F, you just remove it as of here. So G for comes for glucose. So they have a high glucose metabolism, whereas the glycogen store is less. So you have to be very careful about their glucose monitoring, and you have to give dextrose containing food. So the definition of hypoglycemia in a newborn is less than 30, infant is less than 40, and child is less than 60. These are the specific number you have to remember. Next comes H for hematological. So this comes in your physiology question at birth. It is 70 to 90% HbF. At 3 months, it comes to HbF predominates. Whereas in hemoglobin, it is around 18 to 20 gram per deciliter. They have a polycythemia because their oxygenation is not good, so their bone marrow is good. So in a newborn, if you are talking about CDH, never forget to talk about vitamin K dependent factors are deficient. That is why vitamin K has to be given if not given at birth. So I for immunity. So they have in a premature baby, they are prone to infection. Strict asepsis has to be taken care of. Then K for kidney. So the kidney is immature at birth. There is a decrease in renal blood flows to GFR ratio till 2 years. So their concentration capacity is less. So this is what I was asking him. What is the target urine output in a neonate? It is 1 to 2 mils per kg per hour. And they have a decrease in sodium reabsorption. So the tubular function is immature till 8 months. They cannot handle a large sodium. So if you are using the 9.9% NaCl, you should be very careful about the sodium level that rises very fast. L comes for liver. So liver is immature because the hepatic function, enzymes, everything is less. They have a limited glycogen storage. So whatever drug you give, it goes to a longer time. So most of the drugs you give is by, you know, how do the pharmacokinetic happens? It is, I remember, by ADME, absorption, distribution, metabolism, and excretion. Since we give most of the drug as IV, so bioavailability is 100%. D comes the volume of distribution. We have already seen the volume of distribution is high because the total body water is high. So when you give about the loading dose of the water soluble drug like succinate, choline, you have to increase the dose of such drugs. Next comes the protein binding. That protein binding is decreased. That is why the concentration of the free drug is more. Next, they have a less redistribution because their muscle and the fat are less, and they have a reduced clearance. So the maintenance dose has to be reduced. Also, the immature, the hepatic enzyme function is immature. So that is why you have to be very, very careful while you choose for the drug. And also the neuromuscular junction is immature. So volatile anesthetics, their volatile anesthetic concentration or how they achieve their MAC mostly depend on the minute ventilation to FRC ratio. The minute ventilation is high. Okay. So the MAC is achieved very fast. So they are more sensitive to the hemodynamic effect of the volatile anesthetic. So first of all, their FRC though is less, but the minute ventilation is high and the blood flow to the vessel group is more. So that is why they quickly achieve the MAC. And you have to categorically remember the MAC value of the neonate and the infants, and you have to remember the MAC increases up to infancy, then it again decreases. Then few induction agents like thiopentone and propofol. So thiopentone has a reduced dose in newborn than in infants because of the immature blood-brain barrier, and they have a decreased protein binding, which I have already mentioned. In propofol, because of the children, especially after 1 year, they require a bit more than that of the adult. Opioids in newborn, because of the immature blood-brain barrier, the opioids will cross the blood-brain barrier quickly. Also, there is hepatic. As I've already mentioned, the hepatic blood flow, all this thing determines a lot of things. So here the hepatic conjugation is decreased. So cytochrome P450 matures by 1 month. That is why the hepatic clearance is reduced. In children, their hepatic blood flow is more. That is why the dose will be more. In units, we routinely give fentanyl at a dose of 1 mg per kg, whereas in children and the adult, we give at 2 to 3 mg per kg. When it comes to the depolarizing muscle relaxant, as I've already mentioned, in infants, you have to give almost 2 times that of the children. And when it comes to non-depolarizer, because the immature neuromuscular junction is there, the doses are they are very much sensitive to these drugs. And the greater volume of distribution and reduced hepatic renal function will make the clearance more late. So you have to reduce the dose of the non-depolarizers. Then for M comes the monitoring. So here the problem is the age appropriate site monitor. This is always you can talk when you are talking about the newborn or the pediatric consideration. So especially in cases where you expect a preductal postductal differentiation, always in newborn it is better to keep, because that can give you an idea of if there is any transition of the free crop circulation. Also, there is a problem with the capnography. You should use a mainstream capnography, though it is very tedious and heavy and chances of dislodgement is there. And last is temperature monitoring is difficult. So this is a very important question, when to cancel a case for URTI, which this is they may or may not ask in exam, but this is what practically we always face. If a child comes for URTI, whether to take up the case or refuse. But as a people, what I've seen, most of the people go for cancellation, but the recent protocol has come up, and this is from the latest Miller book. So you have to do a preoperative assessment. If the child has a dry running nose, watery condition, it's a mild cough, you can proceed with the surgery. Just avoid endotracheal intubation, avoid desflorin, use LMA when possible, use propofol, and consider lidocaine. If it is a moderate cold, then you have to see the risk-benefit ratio. And how do you define a moderate cold? If there is a purulent condition. The risk factors, if like it's in less than 1 year, is there is a passive smoking, there is a pulmonary comorbidity, it is a like all these problems are there. On the other hand, if it's a ENT surgery, anyway, that is causing itself the problem. In those cases, you have to see the risk benefit ratio and decide whether to go for a surgery or to cancel. And if you decide to go for a surgery, especially when it's a ENT problem, then you can proceed with the same anesthetic management. If it is the thing is associated with fever and malaise, then it's called as a severe cold. Previously, it was called to postpone the surgery for more than 4 weeks. Now it is shortened to 2 weeks. So then you do a re-evaluation. Then comes the P. P is for the practicalities of anesthesia. So whenever you're going to do something, you always have to plan, have to perform, have to prepare, have to perform, and then post-op care. So when the baby comes for a day of visit, you have to record the weight and you have to evaluate. So what we have seen when we are asked what are the investigation you do, people end up telling every investigation, even for just a what is that tongue tie. All the investigation are not needed in every child. However, if this case, as we have mentioned, is IHPSS, there are chances of fluid electrolyte, there are chances of blood loss. In that, you are supposed to answer the specific. However, hemoglobin, electrolyte, and if there is congenital heart disease, respiratory problem, then you talk about chest X-ray. In EDAIC exam, if you talk about more investigation, there is not at all a problem. So don't, here you can talk always about CBC, LFT, RFT, they don't have any problem, but few examiners are very skeptical. If you answer our investigation, they will ask why you want to order this. So you should be even careful with that. And then comes the discussion with the parent. Consent. Consent not just for general anesthesia, or suppository consent is also very important, because you are going to give paracetamol IV, or sometimes you have to give by suppository also. So suppository consent is different, which you have to take, and NPO advice. So in one of the consideration in the IV access is initially newborn IV access is very difficult. So you have to have during the preoperative evaluation along with the airway, you should always talk about IV access. So in the preparation, you have to have a warm table and a warmer machine circuit according to the baby weight and age. The age appropriate monitors, suction and airway equipment kept ready. IV access and the age appropriate, weight appropriate drugs. So this we have already discussed. Then At times they are asking what is the tube size you have to. So for the uncuffed tube, it is the H by 4 plus 4 by 4 plus 4. Cuffed tube 1 down or H by 4 by 4 plus 3. So this thing you have to keep, then whether to go for a cuffed tube or uncuffed tube. So now the people have settled with micro cuffed tube. This is a very good till 8 years of age, and we are getting it also nowadays. Then comes for performing. So pre-medication. So there are various way of pre-medication, pharmacological, non-pharmacological. So as I have mentioned, the separation anxiety is common in 1 to 3 years of child. So if the baby is coming in early infancy up to 7 months, here your primary focus is your parent because child will not understand anything. If the baby is coming in 1 to 3, thing, you have to do everything in the parental presence because separation anxiety is a very important thing. If the child is around 3 to 6 years, your main focus is the child because you have to gain the trust of the child. And finally, if it is more than 6 years, then here you have to have more interaction with the child, that all the play, distraction, technique, toys, this all you have to take care. Then what are the drugs? Previously, people used to give only midazolam. Few people gave only ketamine. So best thing is to give both midazolam and ketamine. And what you can see is this is the nasal dose. The next to the beer is the oral dose, and this is the rectal dose. So the ideal dose that comes is midazolam per ketamine per orally 0.4 mg per kg plus ketamine is 4 mg per kg. Okay. So this we have already discussed. This we have already discussed. One ventilation, the silent one. Okay, and neonatal pain, I was asking him neonatal pain. So in neonatal pain score, there is something called as the NPAS score and a NIP score. They are the behavioral score and the physiological score that has to be taken into account. Okay, am I clear or I was very fast?
No, ma'am, what are the scores?
In newborns, there are two scores. NIP score, NIPS, neonatal infantile pain scale, and another is NPAS.
NPAS, okay.
Okay, they are basically the behavioral pain scores.
Okay. Ma'am, the IV fluids part that got left out.
Yeah, I'm not away. I will finish. I was opening the PPT by that time. Are you clear up to here or I was very fast?
About caudal anesthesia, could you please tell us how to do it and the doses of local anesthetic?
Pardon, I didn't get you.
Caudal anesthesia. Could you please explain how to do it and what are the doses used for main different operations?
I didn't get you, Dr. Omar. You are asking for neonatal anesthesia.
I'm asking about analgesia with caudal block.
Okay, you want me to explain about caudal block. Okay, I will explain that. Fine.
Thank you.
First, we'll cover the this thing, intraoperative fasting and thermoregulation. This is very important. After that, I will come to your query. That thing we'll discuss, whatever I like. So, we know as physiology part is over, we know they have a large blood volume, they have a large extracellular volume, they have a high metabolic rate, and they have a high fluid turnover rate. Okay. So what happens if you give a fluid, it is too much of fluid, then that will cause your organ edema because their lung and kidney are not mature. And if you give less fluid, there will be hyperperfusion and organ damage. So you have to have an optimal range. So how you decide on the fluid? So what basically you want a normal extracellular fluid volume, you want a normal blood volume, you want a normal tissue perfusion, a normal metabolic function, and a normal electrolyte and acid-base balance. So what are the IV fluids do we have? I have hypotonic, isotonic or hypertonic. Isotonic is 0.9% saline, ringer lactate, plasmolite A, and stereofunding. So what I have seen in in repeated years, whenever we ask people what is the fluid you want to give, people come with plasmolite P because they have a notion P is for pediatric and PDP is for maintenance fluid. This is the biggest misnomer. Plasmolite P is the hypotonic fluid which has not to be given. If you wish to give, first choice is your plasmolite A, second is your ringer lactate, third is your normal saline. Stereo funding is commercially preparation name. You can always give that, but keep these three in mind for answering. So next come to colloid. As I've already mentioned, in pediatric patient, it is the 4.5% albumin has to be given. If it is a 25, this is a naturally formed, you should not give. And if you're giving the synthetic one, you should give the higher, like extra starch, higher ones. So initially the formula that was for the fasting was 4 to 8, you know. This thing that sometime ask if the patient get chewing gum, then what is the RO, whether it is 2 hours or it is clear, it's a clear fluid you can think of. So chewing gum comes under 6 hours. Okay. 8 hours is regular milk and 2 hours is clear fluids, and they have also described what are the clear fluids they mean. Okay. However, recent guideline has changed and now they are of the recommendation, this 3 society, and why I am telling you in particular, because this is the Association of Pediatric Anesthesiology of Great Britain and Ireland, also the European Society of Pediatric Anesthesia. So they might ask you what are the recent advances in pediatric fluid management. Now they are encouraging 1 hour of clear fluid instead of 2 hours. Okay. And how much of clear fluid should be allowed to drink 1 hour prior? It is 3 ml per kg. Okay. So these 2 questions for you. Then, and carbohydrate loading. This is a part of the ERAS protocol. Then when you come to fluid therapy, it is not just the fluid. So it is always fluid therapy, volume therapy, and transfusion. First, we'll learn about the fluid therapy. So fluid therapy can be categorized into 3 parts: deficit fluid, maintenance fluid, and replacement fluid. So whenever you talk about deficit fluid, so first you have to think whether the case is an elective case or an emergency case. So if the case is an elective case, then you next decide what is the duration of the surgery and what is the type of the surgery. If it is a less than 1 hour of the surgery, that means it's a minor surgery like circumcision, there is no need of any infusion fluid needed. If it is a 1 hour, like splenectomies, more than 1 hour is a moderate to severe, then you go for a deficient fluid therapy. Because in elective case, we assume that the patient is well hydrated and comfortable. Then second comes the emergency surgery. In emergency surgery, you have to see, like I have already mentioned, most of the neonatal emergency, pediatric emergency, actually not emergency. They are to be medically optimized. Only malrotation of the gut is a real emergency. So you have to see if there is an initial resuscitation has been done or not. If the resuscitation is done, then you have to go for the clinical judgment about the level of the deficit and you proceed. If you see the resuscitation has not been done, then you go for an aggressive fluid management. Then second is why it is needed, because you are on the pre-operative fasting, and which fluid has to be given? It is always the ringer lactate. Be it deficit fluid, replacement fluid, or maintenance fluid, always the fluid of choice is the ringer lactate. So this is what, and this I have already told, and I will tell you how to calculate the fluid deficit. So Dr. Dhania was asking how do you measure the degree of dehydration. So this is a table you should remember, or to some extent important points you should remember is, if it is patient capillary refill is everything is normal, only the patient has a mucous membrane is also moist, but peen skin is springs back. Means overall it is more or less normal. Only a mild degree is defined as less than 5%. Moderate if all these things are present, but urine is normal. but abnormal to reduce, blood pressure is normal or low to static hypertension is 0. It is 6 to 10%. If everything is very severe, patient is lethargic, almost severely reduced, shrunken, spontaneously severely shrunken, there is prolonged tenting, that is severe. Then somebody asked me in one class that, ma'am, how do you define whether it is 6%, 7%, 8%, 9%, or 10%? There is no clear-cut classification on this. Even I don't know. It is, you can just take a average. This you can further classify. There is no proper classification given by any society till now. 6 to 10, you depending on the severity of the symptom, you only decide it's 6, 7, 8, or 9, or 10. So the formula is fluid needed in mils is 10% of the 10 into percentage of dehydration which you derive from the table into the weight of the baby. So that is the ml of the fluid which has to be given as a deficit fluid. Okay. Second comes the maintenance therapy. So for the maintenance therapy, the holiday SIGA formula which you have already mentioned, it's correct. It has to be given and the fluid given is the RN. Again, the NICE guidelines are of the opinion that in newborns, there is a non-osmotic EDAIC secretion. That is why you have to reduce the maintenance fluid calculated to 50 to 80% of whatever calculation you come up. And in maintenance, the dextrose which has to be given is 1 to 2.5% and not the routine 5 to 10%. Then comes the replacement therapy. So in replacement therapy, again, what you have to give? You have to give the Ringer's lactate. Only exception is IHPSS, which I was looking for. Here, because the chloride replacement has to be done, so you go for a normal saline. Okay. And this is the replacement fluid. If it is for a superficial surgery, it is 2 ml per kg per hour. For 4 to 7 ml per kg per hour for thoracotomy, and for abdominal surgery, 5 to 10 ml per kg per hour. So this is the third space loss. As of now, in adult, there is again a like confusion whether to give or not. But in pediatric, it is still you have to give the replacement fluid. So which fluid we have already mentioned? First is the plasmolyte because it is not dependent on the liver. There is, yeah.
Why in adult you said that this
Actually,
correction?
There is a confusion of recent whether to give replacement fluid in adult or not. Okay, like there is also like third space loss because replacement fluid is not just the surgical. There is this concept of the interstitial fluid loss, third space loss. So they are of the opinion there is no third space in adult. But as far as pediatric is concerned, they are still of the opinion that there is a third space loss.
Okay. So like in a trauma case and we don't say or replacement fluid?
Trauma in adult or in pediatric?
Adult I'm asking.
Adult, see, whatever blood is getting lost, that is, I'm talking about fluid therapy.
Fluid,
Again,
yeah, I know.
Yeah, I'm not talking about blood therapy.
Mm.
Fluid therapy about the third space loss, that is the interstitial space loss. In
Yeah,
adult,
like abdominal surgery.
Yeah, abdominal surgery. So they, especially that interstitial fluid loss, they talk, no, that is the third space that whatever intravascular is there, it go to the interstitial space. That's the third space loss. If the fluid is getting evaporated, that is not third space. And that is not what they are saying. They are mainly confused. They are mainly controversies between the interstitial fluid loss. So that is there in adult. So that is they are saying there is no third space in adult. But in pediatric, as of now, it holds if there is a third space loss. Okay. So whether to give plasmolyte or linger lactate or normal saline. So normal saline is the problem of high chloride and as I already mentioned sodium also. Linger lactate is hepatic function. Second thing is ABG will not give the proper number of lactate. That is why the best choice is plasmolyte A, not E. Second is the volume therapy. So volume therapy, what do you say? Do you want to give colloids? The answer is no. As a volume therapy, don't confuse with the resuscitation, what I told in meningococcal meningitis. That is a fluid therapy. Here at the blood therapy, do you want to give if there is a blood loss? Do you wish to give colloid? Answer is no. You should not give. Try to replace the blood with the blood. If at all the blood is not available, that is unexpected blood loss, then you replace with colloid till the blood comes. And if at all you want to give, the best thing is give 5% or 4.5% albumin. If this is not present in your OT, then you go for a higher generation with a starch of 150. And how much to be given? 5 to 10 ml per kg up to a maximum of 50 ml per kg. You should not give a high dose of Pillard. Okay. Then preoperative blood loss. So you have to go for a allowable blood loss if it is 10 to 20% or a transfusion trigger of 7 to 8. So people usually ask whether to go with this or this. So you have to understand what your patient is for. Suppose the patient is posted for splenectomy. His baseline hemoglobin will be very less. So this will be considered as a transfusion trigger. If the patient has come to trauma, so this will be considered as a transfusion trigger. Okay. And the volume of PRBC that has to be given is weight into desired increment into hemoglobin into 5. Okay. And how fast to start the enteral feeding? Early the best. And if you want to give first 12 hours IV fluid in the post-operative, it's not the holiday cigar formula with which you should give, rather you should half it, 0.5. Then next thing we come to is temperature. So you know what are the problem of cold temperature or hot temperature? They finally go to the lateral spinothalamic tract and go to the anterior thalamus, hypothalamus. Whereas if you that anterior hypothalamus will stimulate the posterior hypothalamus, that will show the response to cold as the behavioral. You try to move away or you try to wear something, cutaneous vasoconstriction and shivering. In response to the warm, so there will be behavioral, again you try to put on your AC, or there will be cutaneous vasodilation and sweating. So few terminology you have to understand is a threshold temperature. Threshold temperature is the central temperature that elicits regulatory effect to maintain normothermia. Interthreshold range is the temperature over which no thermoregulatory response happens. Okay, and mean body temperature is the physiologically weighted average temperature for various tissues. So for here you remember the interthreshold temperature range. That means now my body is at 36 degree. I move to 36.1 degree. In that small range, okay, nothing will change. That I can adjust. Suppose I move to 38 degree. That time I will start feeling like I'm feeling very warm, that cutaneous vasodilation will start. I will get sweating. So 36 to 36.1 is the interthreshold in which nothing will happen. Above or below, there will be something that will happen. Non-shivering thermogenesis is the metabolic thermogenesis above the basal metabolism and it is not associated with the muscle activity. So this you have to remember. And shivering is a voluntary muscle activity. So this is the difference between the non-shivering and shivering. One is above the basal metabolism and involuntary muscle activity, but there is no associated muscle activity, whereas in shivering, it is a voluntary muscle activity. So this slide we have already mentioned. So the heat productions overall goes more slowly and lose more quickly. So the thermoneutral zone is around 32 to 35 degree in children. So this is another question they will ask you, what is the most mechanism of heat loss? Most of the people answer as conduction. It is the radiation which accounts for around 39% of the heat loss, followed by convection, then evaporation, and last is conduction. And these are the sites of non-shivering thermogenesis. They might ask you, what is the non-shivering thermogenesis? What is the trigger of non-shivering thermogenesis and how it is done? So this is the mechanism. Generally, what will happen when there is a cold stage, there will be activation of the sympathetic activity, which will cause the increased lipase activity in the brain. And finally, there will be the uncoupling 1 activation, uncoupling 1 UCP1 protein activation, which will cause the protein conduction along the internal mitochondrial membrane and heat will be released. The problem is the drugs which you are most commonly using, your propofol, fentanyl, they all inhibit the non-shivering thermogenesis. So that is why we are at problem. So what happened in hypothermia under general anesthesia? There are 3 phases. One is the phase of internal redistribution of the heat. Then comes its phase of thermal imbalance and finally a plateau or a rewarming phase. So first phase, what will happen? The core body temperature, there will be an expansion. You can see, so this was 37, core will go down, periphery will get cold, so there will be contraction of the outside the peripheral compartment, there will be expansion of the core compartment. So when this is the first response. So actual heat loss is overall minimal. Then comes the phase of thermal imbalance. Here the heat loss will be high and production will be less. And we know why there is an increase heat loss and decrease in production. So overall, there will be decrease in the blood temperature of around 0.5 to 1 degree centigrade per hour. Third is the thermal steady state or the rewarming phase. So here the other thing like vasoconstriction will start. Okay. So there will be contraction of the central core temperature and there will be expansion of the periphery. Okay, so overall there will be increase in the core temperature. So you can see the compartment will expand, peripheral will compart, but this much will be the core. So the temperature will increase. Okay, this is where your passive rewarming will help. So warm blanket and all will help you to arrest this phase at this only. Okay, so if there is a hypothermia, there will be activation of the norepinephrine pathway, there will be increase in the PVR, there will be increase in the lipase activity, there will increase in the SVR. So overall, there will be tissue level hypoxia. So under GA, what I was talking about thermoregulatory range, suppose it is 36 to 38. If the body goes less than 36 degree, then there will be vasoconstriction, non-shivering thermogenesis, or if the bigger child, there will be shivering. The opposite happens when it goes above 38. But what problem is under anesthesia? This inter-threshold range increases. The one which was responding at 36 will now respond at 32. On top of it, your vasoconstriction, because sympathetic has cut off, it is gone. Next comes non-shivering thermogenesis. Your propofol, inhalational, and everything will inhibit it. And shivering is never an option for them. That is why they are prone for even more hypothermia. So this is the definition of hypothermia according to WHO. What is mild, moderate, and severe? You have to remember it. 36 to 36.4, and moderate is 32 to 35.9, and below 32 is severe. And these are the sites of measurement. Most commonly, the nasopharynx is used clinically. And this is how do you prevent hypothermia. So OT temperature of 27 for full term, 29 for preterm. Few examiner want to answer 27 only. So 26 to 27 is what they want to answer. If you're using irrigation fluid, it should be at a room temperature. Humidity of the room should be around 40 to 60 degree. And warming mattress should be set at 40 degree. So 6 Ws are the warm hands, warm OT surface, warm fruits, post air warmer, warm blanket. Okay. I told 6 or 5 by now. You guys are there or only I'm talking?
We are here, ma'am.
There, ma'am.
Yeah, we are here, ma'am.
Okay. So, am I clear?
I have a question, please, about the glucose-containing fluid in intraoperative or perioperative management. Do we should inunate using 0.45 dextrose with normal saline?
In units also, you are supposed to give 1 to 2.5% of dextrose. You should not give 5%. And in pediatric patient, only in patient whose mother means who has mitochondrial disease, central myelin or liver disease, or mother of a diabetic mother in the first 1 month. In those cases, only you go for a glucose. You should not routinely give 5 or 10%. That is obsolete now.
Sorry, I mean 0.45, 1/4 or 1/5, isn't it? Dextrose.
1 to 2.5 percentage. This is dextrose. Oh, sorry, I missed. Yeah, this is the percentage of which you should. Dextrose, I mentioned in the chat box. So any doubt? Was I very fast, very slow, too much of input, which is difficult for you guys?
Too much of information in a short time.
Yeah, this is maximum I can do. Just one.
Hi, everyone. Can you guys hear me?
Yes, sir, we can.
Perfect. Perfect. I think we'll take a short break now. Let's say about 15 minutes time, and then we'll start with the mock Viva with Dr. Dasgupta. So I think you guys have had a long session this morning. If you can stretch yourself, have a cup of tea or coffee, and then we'll reconvene in about 15 minutes time. Is that reasonable, or you want a bit longer break?
So I'll have to leave. I have some work. I think the rest are